Let's dive right into this explainer. We are immediately executing an intense clinical matrix simulation targeting a 270-plus score. We're bypassing the basics entirely and plunging straight into high-yield, complex clinical scenarios. This is all about sharpening your pattern recognition and solidifying your management algorithms to an absolute expert level.
Throughout the simulation, we're maintaining a rigorous peer-to-peer professional tone. The expectation here is exhaustive mechanism mapping and precise management steps, without hesitation. We are going to deconstruct the exact pathologies, the discrete management requirements, the hidden traps, and the critical exceptions that separate an average clinician from a true diagnostic master. So prepare to dissect every single variable.
Module 1. Vestibular kinetics and nystagmus parameters. Let's diagnose the exact etiology of episodic versus persistent vertigo.
First up, we absolutely must outline the stark mechanisms dividing two classic peripheral presentations. Consider benign paroxysmal positional vertigo, or BPPV, against Meniere's disease. BPPV is driven by mechanically provoked calcium debris, canaliths, displacing strictly within the posterior semicircular canal. Meniere's disease, by contrast, is driven by an idiopathic fluid distension. It's an endolymphatic hydrops, creating a classic triad: episodic vertigo, fluctuating sensory neural hearing loss, and low-frequency tinnitus. The underlying pathology strictly defines the clinical picture.
Now, the crucial point here is the duration. BPV strictly drives transient vertigo lasting less than 1 minute. That's it. This is an absolute diagnostic marker. It's provoked strictly by specific head movements and confirmed at the bedside with the Dix-Hallpike maneuver, which elicits a fatigable, upbeating torsional nystagmus. Listen, if the room is spinning for hours, you must eliminate BPV from your differential entirely.
Let's isolate these singular variables distinguishing the brief, mechanically provoked episodes of BPPV from vestibular neuritis. While both cause severe room-spinning sensations, vestibular neuritis is a constant, severe, post-viral attack on the vestibular nerve. It lacks the auditory symptoms you'd see in labyrinthitis, meaning the patient's hearing is perfectly intact, but the vertigo is constant. It lasts for days, not seconds, and is accompanied by a positive head thrust test.
For acute peripheral vestibulopathies, like vestibular neuritis, we have to recognize the absolute therapeutic window. Corticosteroids must be administered within 72 hours of symptom onset to maximize vestibular recovery. If you miss this window, you're severely compromising the patient's neurologic compensation.
Let's apply this directly to an integrated assessment. You have a 40-year-old presenting with a 2-day history of continuous, severe, room-spinning vertigo, nausea, and horizontal nystagmus right after a viral upper respiratory infection. Crucially, auditory testing reveals completely intact hearing. This scenario strictly tests your ability to map the exact pathology based purely on history and nystagmus presentation.
And this brilliantly illustrates the exact traps we face in high-stakes environments. Let's exhaustively break down all 5 options. Option A, Meniere's disease requires hearing loss and tinnitus, so that's incorrect. Option B, BPPV triggers episodes lasting less than a minute, not continuous days, so that is out. Option D, acoustic neuroma causes a gradual unilateral sensory neural hearing loss, which completely misses this acute post-viral presentation. And option E, cerebellar stroke, while that's a central lesion driving direction-changing nystagmus and severe ataxia, not an isolated peripheral pattern. Therefore, we must correctly select option C. Vestibular neuritis perfectly maps to the post-viral, persistent vertigo with normal hearing and a positive head thrust test.
Module 2. Pediatric neck mass embryology. This domain demands strict anatomic and embryologic mapping, where physical exam findings instantly dictate your diagnostic imaging and surgical management.
Let's map the distinct etiologies of 2 common pediatric congenital masses. We're contrasting the thyroglossal duct cyst, which is a midline migration failure that uniquely elevates upon swallowing or tongue protrusion due to its persistent attachment to the foramen cecum at the base of the tongue. Against this, we map the branchial cleft cyst. This arises from the incomplete obliteration of the second branchial cleft, strictly presenting as a lateral neck mass positioned anterior to the sternocleidomastoid muscle. Location and movement are your absolute primary anchors here.
We have to highlight the exact physical exam variance that dictates our diagnostic pathway. A thyroglossal duct cyst presents as a firm, midline mass that is highly mobile with swallowing. Conversely, a cystic hygroma is a severely malformed lymphatic network presenting as a soft, intensely fluctuant, transilluminating mass. It's typically found in the posterior triangle of the neck and is heavily linked to the 45X genotype of Turner syndrome. This clinical divergence is absolute. Okay, let's map an integrated assessment to determine the absolute next step in management. We have a 5-year-old boy presenting with a painless, midline neck mass. During the physical exam, the clinician asks the child to stick out his tongue, and the mass clearly moves superiorly. The diagnosis of a thyroglossal duct cyst is clinically apparent right away. Now we must systematically eliminate the incorrect management steps. Option 1, immediate surgical excision via the cyst trunk procedure, is the ultimate treatment, but it is incorrect as the immediate next step. Option 2, fine needle aspiration, is completely unnecessary and unhelpful for this classic congenital presentation. Option 3, reassurance, is wrong because this tract is highly prone to recurrent infections. Option 5, incision and drainage, is reserved solely for acute actively infected abscesses. This leaves us with option 4, neck ultrasound. This is the strictly required diagnostic intervention to confirm the presence of a normal ectopic thyroid gland before any surgical excision takes place.
I want to really emphasize this critical surgical parameter. You cannot excise a thyroglossal duct cyst until ultrasound confirms normal thyroid tissue lower in the neck. In some patients, the cyst is literally their only functioning thyroid tissue. Confirmation dictates the scalpel.
Module 3. Salivary gland neoplasms and cranial nerve 7. In head and neck oncology, recognizing neoplastic progression requires immediate, high-fidelity pattern recognition.
Let's detail 2 discrete benign salivary masses. The pleomorphic adenoma is the most common benign salivary gland tumor, presenting as a painless, slow-growing, highly mobile parotid mass. Its histology strictly reveals a biphasic matrix of epithelial and chondromyxoid stromal tissue. Contrast this with the Werthin tumor, also known as papillary cystadenoma lymphotomatosum. This is a benign cystic tumor heavily associated with older male smokers, distinctly known for its dense germinal centers and cystic spaces.
So, the crucial point here is the clinical divergence into malignancy. Pleomorphic adenomas are painless and mobile, leaving the facial nerve perfectly intact. However, a malignant transformation or a primary mucoepidermoid carcinoma presents completely differently. It invades locally, fixes firmly to deep connective tissues, causes severe localized pain, and most critically, paralyzes the ipsilateral facial nerve.
Let's introduce a high-stakes clinical vignette. A 60-year-old male smoker presents with a new, rapidly enlarging right preauricular mass. He reports severe localized pain over the past 3 weeks. On exam, the mass is firm and fixed to the overlying skin. Crucially, you note a severe right-sided facial droop and the patient's inability to fully close his right eye.
Let's execute the exhaustive breakdown of each option here. Option A, pleomorphic adenoma, and option B, Werthin tumor, are entirely benign. They do not cause rapid growth, pain, or facial nerve deficits. Option C, sialolithiasis, is a salivary stone causing colicky postprandial pain and gland swelling, not a fixed neoplastic mass with cranial nerve invasion. Option E, squamous cell carcinoma, usually presents as an ulcerated mucosal or cutaneous lesion, not a primary parotid mass. Therefore, option D, mucoepidermoid carcinoma, is the only correct diagnosis. It perfectly maps to a primary malignant salivary tumor demonstrating aggressive paraneural invasion.
And this brilliantly illustrates a hidden trap in head and neck pathology. You must recognize that the onset of a facial nerve palsy in the setting of a parotid mass is not just some coincidental Bell's palsy. It is driven entirely by malignant perineural invasion. Immediate oncologic staging, not just clinical observation, is the absolute required intervention.
To cement the benign differentials in your memory, isolate this exact statistical marker. The Werthin tumor carries a strictly 10% rate of bilateral presentation. I want you to use this 10% as your high-contrast visual anchor. When you see an older male smoker with bilateral parotid swelling, Werthin tumor immediately moves to the top of your diagnostic list.
And with that, the clinical matrix is complete. We've successfully mapped vestibular kinetics, complex embryologic neck tracts, and malignant neoplastic progression. But remember, medicine is incredibly dynamic. I want to leave you with this provocative thought. As you review your next clinical vignette, what singular systemic variable, maybe a subtle reflex, an intact nerve, or a very specific timeline, will entirely alter your next diagnosis? Keep dissecting those details, and I will see you in the next explainer.